speakers. Lee McCall is the Chief Executive Officer of the Neshoba County General Hospital and Nursing Home in Philadelphia, Mississippi. Mr. McCall is a fellow of the American College of Healthcare Executives and current chairman of Healthcare Providers Insurance Company. He is also a member of the Mississippi Hospital Association Solutions Board of Directors, Magnolia Evergreen ACO Board of Managers, Mississippi True Health Plan Board of Directors, Institute of Healthcare Executives and Suppliers, and a former member of the Mississippi Hospital Association Board of Directors. Dr. Heather Cannon is currently practicing family medicine at Neshoba Medical Associates, a division of Neshoba County General Hospital and Nursing Home in Philadelphia, Mississippi. Dr. Cannon earned a doctorate of medicine from the University of Mississippi School of Medicine and performed her internship and residency in family medicine at the University of South Alabama Medical Center. She is board certified by the American Board of Family Practice, is a member of the American Academy of Family Physicians, and is a member of the Mississippi Academy of Family Physicians. Dr. Cannon currently serves as the Chief of Staff and ACO Medical Director for Neshoba County General Hospital. Now I'll turn it over to our PMG call facilitator, Terry Hill, Executive Director of Rural Health Innovations and Senior Advisor for Rural Health Leadership and Policy at the National Rural Health Resource Center.
Thank you very much, Kim, and good morning, everyone. The topic of the day is Success Secrets from an ACO High Performer. And I'm really excited about this call because what has happened, as many of you know, is that over the last several years, we've seen the emergence of rural hospitals, rural clinics, into accountable care organizations. We originally started with this model, which was largely an urban model, and recently it's been far more focused on rural. In fact, most of the accountable care organizations in the past several years have been rural. And we also know that many of these accountable care organizations have been very successful. And in fact, given the research that was produced a few months ago, we see that smaller rural ACOs are actually outperforming the bigger urban ACOs. And there's been a variety of reasons for that, many of which you might be able to guess, that despite the small size and somewhat limited resources, that rural hospitals can change quicker, are in many cases capable of pulling off savings and meeting some of the accountable care organization goals quicker, and in many cases more extensively than some of the traditional accountable care organizations. Unfortunately, there's been very, very little research done on accountable care organizations in general. And if we look just at the rural accountable care organizations, we see that the University of Iowa has a contract through their Rural Health Value Program to kind of keep track of what is happening. But to some degree, we're going to have to look to leaders like Mr. McCall and Dr. Cannon to tell us about what we're learning here and to be able to translate the knowledge as we're kind of tapping into it. And hopefully this call will provide a means of kind of transferring that knowledge as well. So with that, I'm going to ask Lee, tell us a little bit about your hospital. You know, basically how long have you been there? And maybe then Dr. Cannon can talk about, you know, when she joined the medical staff, et cetera. But I'm just looking for kind of an overview of your hospital, what part of Mississippi you're located in, how big you are, et cetera. Lee?
Okay. Thank you, Terry, for having us here today. We certainly appreciate that. course, my name's Lee, and I've been here approximately 3 years now. Neshoba is located in east central Mississippi, close to the Alabama line. Our hospital is a PPS sole community hospital. We have 48 acute beds, 10 of which are an inpatient geri-psych unit. We have 160 bed skilled nursing facility. Our ED volume is approximately 22,000 annual visits. Acute discharges annually right at 1,400, along with 700 or so observation discharges. Our geri-psych unit is about 200 annually discharges. We currently have 2 rural health clinics, one of which is an integrated practice between family medicine, pediatrics, internal medicine, medical oncology. Our other is a urgent care and family medicine location. In those 2 clinics, we have 7 physicians and 7 nurse practitioners. We also operate a surgery practice with orthopedic surgery and general surgery, and our clinic's combined annual visit count is 52,000. Other services we offer are sleep medicine, wound care, pain management, oncology, infusion, and just a host of other programs as well. But that's us in a nutshell.
Could you tell me a little bit more about what kind of population do you have? Do you classify it as high need? Tell us a little bit about the service area as well, if you will.
Sure. Our population is approximately 28,000. We are located in Neshoba County, which also has the Mississippi Band of Choctaw Indians located within our county. They have their own health system that they provide services to their population, but we also provide services to them as well. We are in an underserved area. Median income is probably around $25,000, $26,000 annually. So we certainly are your typical rural community.
Okay. Dr. Cannon, could you tell us a little bit more about yourself?
Sure. As was mentioned, I'm trained in family practice. I'm originally from North Mississippi and did my training in South Alabama. And I worked in student health at the University of South Alabama for about 3 years before we had the opportunity to move back to Mississippi and coming here to Neshoba. I've been here for about 3.5 years now.
Oh, okay. Lee, back to you. Why did you consider joining an accountable care organization? It's certainly not a decision that most rural hospitals have made at this point. Tell us a little bit about why you decided to move in that direction.
Well, all of us realize that the healthcare model is changing to a population management program where certainly reimbursement is changing from volume to value, and certainly we all have been made aware of this through various articles or different meetings and such, and we've always had interest in getting more involved, but haven't really had that opportunity being a small rural provider. We're independent, we're a county-owned hospital, so we don't have a large population we serve, and certainly to be able to become an ACO, we would need access to a larger Medicare population. So that the interest has always been there, just the opportunity wasn't. And certainly when we found out about the AIM grant program and and its collaborative approach to bringing rural providers together so that we could share in the attribution and meet the numbers, it certainly gained our interest.
So the AIM, for those of you that may not be aware of it, was an ACO investment model that CMS made available. So Department of Health and Human Services, in an attempt to motivate smaller and largely rural participants in the ACOs, made funding available, and this funding basically paid for some of the development costs of preparing for the ACO, for gaining access to the information that would be needed to help do training, etc. And so basically, kind of give me a feeling for how did this progress. So you had that interest, AIM funding was available. Where did you seek resources and support?
As we learned more about the program, and things moved really quickly, I believe I was at a meeting in late May, and the AIM grant, we had to turn in our application by 2 months, by July of that same year. So we were on a short time frame. And as we looked into it and evaluated it, the risk that we were looking at was really low. Certainly the AIM grant was going to pay more or less the shared savings that was anticipated that we could achieve over 3 years to help us fund the program. So that was a risk that we weren't staring against, was how we're going to fund the operations of the ACO. And the other was we would still be able to bill fee-for-service and collect payments as usual. So that certainly guided us, and then we just, again, started evaluating its benefits and spoke to a lot of our key staff here and our board and gained their support, and we moved forward.
And where did you get the support to be paid for by the AIM program?
I'm sorry, say that again.
Who did you go to then for support to purchase the support you were going to need to become a part of an accountable care organization? So
Caravan Health, which was called NRACO back in 2015, was the group that was making application for the grant, and they certainly had the resources with the data engine to gain access to it and all the resources that we needed to participate in the ACO. So who we gained support from was certainly our board, but the resources or the management group is Caravan Health.
Now that you brought up the board itself, why don't we talk about that a little bit? Some of the reports that I get back from hospitals is that boards have been kind of a difficult group to deal with because it really does involve a pretty sophisticated understanding of the new payment models and, the shifting from volume payment to value payment, et cetera. Talk a little bit more about how receptive was your board? Did they have questions? Did they jump right in? What do you think? What happened?
Well, to be honest, it's pretty challenging to explain this on such short notice, what the benefits are, the transition from the value, from the volume proposition to the value proposition. So you really have to begin working on it all along the way and educating your board, which is what we had done. And when the opportunity presented itself, we tried to hit the high points, not get into the weeds. Sometimes that's difficult to do when you're talking about such an extensive program like an ACO. But our board was receptive. It's part of our strategic plan to advance population health management and community outreach, and certainly this is a key avenue that provides that. So the board was supportive, and it helped knowing that our out-of-pocket and risk was really low, and that we were going to be able to learn how to play the game, if you will, in an ACO and population health management without a lot of downside risk. So they were very supportive.
Yeah, and to some degree, the improvement in the population's health would be something that the board would recognize as having value, and particularly if there wasn't a lot of financial risk. What I hear you saying is that would appeal to them, and so they were on board. Let me ask Dr. Cannon. because another huge obstacle we sometimes see out there, and this is such an important partnership, I just really want to stress that, is the medical staff's involvement and support. Dr. Cannon, can you talk a little bit about, kind of what was the perception on the part of the physicians, and tell us a little bit about how this idea was introduced to the physicians and kind of what their initial and then ongoing support was.
Sure. I think for most of us as physicians, nurse practitioners, providers, we don't know a lot about the value-based reimbursement or even the volume-based reimbursement. I mean, I graduated from medical school relatively not that long ago, 10 years ago, and residency 7 years ago, and I don't remember any training whatsoever on reimbursement issues, and they taught us how to take care of patients, but didn't really teach us anything about that part of it. So all of this is really pretty foreign to us. I mean, most of us just come to work to take care of patients and really don't give a lot of thought to the billing and coding and that side of things. So it's a little, I mean, it's overwhelming when we start talking about moving to an ACO and quality measures and value-based reimbursement. And I think what's worked well is we have staff meeting every 2 months, and we have I've tried to introduce little bits of information along the way at each of those meetings instead of trying to give all of the information at one time, talking about quality measures and then talking about how risk scores are calculated with the HCC categories and the importance of annual wellness visits, and really kind of gotten people on board by doing this a little along the way as opposed to really just overwhelming them with information all at once. And I think we just all recognize the importance of improving our population's health overall with, these are things that we need to be doing to take care of our patients, the quality measures that are measured and everything. And I think sometimes we get a little lax about it when we're trying to get everything done when we're seeing a patient. And really, I think people have gotten on board well, and not just the providers, but the nursing staff as well. We've educated them on the importance of the quality measures, and they are such a big asset in helping ensure that the providers are catching those things sometimes. So to me, what has worked the best is just, like I said, just doing this a little along instead of just overwhelming the providers all at once in the beginning.
Hey, Terry, I'd like to add something I meant to do earlier is we're very fortunate here. We employ most of our providers on our medical staff, and so we have a close-knit group. Dr. Cannon mentioned we have every other month medical staff meetings. The opposite month we have a PI meeting. But since we've been in the ACO, we've had steering committee meetings, and with Dr. Cannon's leadership as our ACO medical director here in Neshoba, we've been meeting twice a month on just different subjects. Our core group of folks, whether it's our care coordinator, our practice manager, Dr. Cannon, some of the ancillary staff, hospital case management folks. So we really begin enhancing that discussion about what we should be talking about and the efforts that we can make.
Yeah, let me summarize that because I think these are a couple of very important points here. And the physician buy-in and support is absolutely one of the most important critical variables for success here. And what I hear Dr. Cannon saying is that this happened over a certain period of time. It wasn't just thrown at them out of the blue, that you have worked with your medical staff, your nurses, etc. So it's kind of an investment in in education, engagement, etc., and that's an important part. Then I also heard, I think from Dr. Cannon, that the physicians saw this as good for their patients. It might be good for the hospital too. It might be good for our financial bottom line in the future, et cetera. But again, the point I want to make is that what I hear is that we have an easier time convincing the physicians to participate if it's good for their patients, and if we take the time to involve them and kind of keep them in the loop on everything. One other quick point I wanted to make is that while I think it's probably an advantage to employ physicians, I've heard from some ACO leaders that it's not the magic solution, though, because you can employ physicians, but that doesn't necessarily mean you bought their ongoing involvement in your new model. And to some degree, I've heard that sometimes the employed physicians can be pretty uninvolved and, just let me do my job, et cetera. So to me, it's an accomplishment whether you employ your physicians or not to engage your physicians and actually have them as active participants. And again,
right,
go ahead.
And I would say that is exactly right. You've got to have good physician leadership in engaging those physicians, because you don't want it to be pushed across as another agenda item from the administration standpoint. And so that was critically important for us, is identifying Dr. Cannon's ability to be able to relate and educate, get involved, and that to me has been one of the most critical pieces of this altogether is her involvement and belief in it, and really driving that home to our medical staff.
Yeah. And as you both know, it's virtually always about the leadership. So the leadership is crucial both at the medical staff level and also at the CEO and senior leadership level as well. Now, one of the things I know is that it takes at least 5,000 Medicare recipients to qualify as an accountable care organization. My thought would be you probably didn't have 5,000 covered Medicare recipients in your service area. So how did you meet the larger requirements for more participants?
Okay, so I'll tell you a little bit about that. Our attribution is less than 2,000 lives here at Neshoba. So the collaboration works in such a way where other hospitals and other communities join in together. So our ACO has 4 providers, main providers in Mississippi. We have 3 hospitals and then one large primary care group in a neighboring county. But we still didn't quite have the number of lives that we felt comfortable with, and certainly through Caravan's guidance and oversight through this process, they recommended that we go outside of our state and find some additional partners, and it so happened to be that we joined up with 4 hospitals in Washington State. When we brought in Washington State, our total attributed lives hit right at 12,000. So that gave us a comfortable number because, as you know, sometimes Medicare patients opt out, sometimes they move, and your attribution, it changes pretty frequently. So you need to have a comfortable number. And so
yeah, right. Attribution has been a kind of an issue with rural, especially where a hospital may think that they have a covered life, and then it turns out to be given to somebody in an urban center in that regard. I think there's also something about having a larger number. The 12,000 to me makes that, you know, you're not at risk, but it just makes it easier to carry on an accountable care organization, let's say, than 5,000 or 6,000 at that particular point. So, and this is really interesting. I spoke in Texas to a whole bunch of rural hospitals last week, and I was bragging about this ACO that had hospitals in both Mississippi and Washington, and afterwards I had more questions about that than anything else. It's like, how can it possibly be? How can hospitals in Mississippi partner with hospitals in Washington in two different states, two entirely different? One's got Medicaid expansion, one doesn't. You know, one's in the north, one's in the south. You can't think of, you know, that those are pretty opposite settings in that regard. To talk a little bit about, when you heard about that, what did you think, and how did you make it work?
Well, certainly we all applied for it, you know, and so the Washington group they were kind of the same category as us. They were right on the brink of having enough lives, but just not quite enough. Initially, when Lynn at Caravan indicated that we needed to add some partners to our ACO, and she mentioned Washington, we thought the same. We're like, how is this going to work? Because we don't know them. We don't know anything about what happens in Washington. So, you know, there were a lot of questions that we had, and I know they had as well. But certainly, as we took off, we quickly realized that they had the same philosophy as us: take care of their communities, manage the health of the populations they serve, and they were in it for the right reasons. And so we quickly got over you're in a different state and a different part of the U.S. barrier, and began really working on how can we better affect, you know, or bend the cost curve for the patients we serve. I think a unique point to mention about this rural ACO model is, yes, we join with several partners to get the numbers, but in a lot of ways we act kind of like our own ACO in our own community. We're managing our Medicare lives, and they are as well, and sure they aggregate, and you look at the combined numbers and combined ratios. But in a lot of ways, we're serving our communities. So it's been interesting, to say the least, and maybe that's why it's worked so well, that we've got a partner from a different part of the U.S., and they have opportunities that are different than ours, and we've both been able to achieve results on those opportunities, and it's had great success. So.
Yeah, and I've worked with several of the hospitals in Washington and been on a panel with one of the administrators. And one of the things you do share, two things I can think, is first of all a real commitment to your communities, whether they're folks from Mississippi or Washington, you kind of share the values of a rural hospital and the challenges as well. The second thing, and I keep coming back to it, it's really about great leadership here. And for example, I was on a panel with Shane McGuire, who's at the Dayton General Hospital, and they've done a tremendous job just in terms of turning that hospital into a kind of a value-based contributor, and have done extraordinary things in their community as well. So I think when you have the committed leadership and you bring the two groups together, you don't necessarily have to be a few miles apart. Okay, so we've got the Accountable Care Organization up. It's running. We have these very disparate, different types of partners in 2 different states. What were some of the initial challenges? What kind of challenged you beginning this?
Well, I think initially it was just trying to understand the concept and how this really works, because this was new to all of us. So there was a pretty good learning curve we had to get over, and certainly trying to communicate that to our constituents, our organization, our board. It took some time to finally get everybody to grasp what it was we were talking about, and I'll get to that a little bit more here in a moment. But then we had to develop a team of people who shared the same belief and the same goals, and we certainly found the right care coordinator, and the care coordinator is just pivotal to the success of the program. Our medical director, our practice manager, and just engagement of our ACO champion, and then having those meetings. And then from an IT standpoint, I would say it was somewhat challenging. It wasn't overbearing, but we certainly had to interface our EMR system to the light beam for the data parts, so we could send information and receive some information. But then I think those were probably the initial challenges. It all began really to start hitting home as we began getting the results from the ACO's performance, and then we could really, instead of talking about it in theory, we could show the results. One, for example, was wellness visits on the Medicare population. Our combined ACO missed out on about $2 million in net revenue in 2015 by only providing about 10% of wellness visits to the Medicare beneficiaries. I think for the most part, Medicare wellness visits are just something they're not done. A lot of times the Medicare patient comes in and sees their provider, and they have a list of things that they go through, and the wellness visit, it just hasn't really hit home for our community. And so we quickly moved from, in 1 year alone, from about 10% right up to about 30% of our total Medicare population. So that's a huge improvement. That's additional revenue, and certainly it generates some other opportunities, such as mammograms, colonoscopies, different screenings that you should be providing and sometimes overlook. And And that, again, goes back to the whole population health model of prevention and wellness. So those are some of the things that I would say were challenges, and as soon as we began seeing the results, it really started hitting home. And Dr. Cannon mentioned the HCC coding and the risk-adjusted scoring. We started seeing our physicians really start participating and asking questions, whereas before they were sitting there trying to figure it out. And then I would say, as we learned our shared savings that we were receiving in the first year, the light went off, and everyone was like, wow, now this makes sense. So, do you have anything?
No, and I think still a lot of it was just education. Mentioned the annual wellness visit. I think as providers, sometimes we thought we were providing our patient with an annual wellness visit, what we would consider a wellness visit. We would try to, they may come in sick, and we may try to address all of those issues without really understanding that Medicare pays for a separate annual wellness visit every year. Just educating that that's something we should be getting. I think we were all trying to take care of our patients to do those preventative services without really understanding that we could be having an additional visit.
Right. And I think you mentioned two really important takeaway points here. One of them is that annual wellness visit, and whether you're in an accountable care organization or not, it's a really good source of revenue on a regular basis to have an annual wellness visit for Medicare patients. Medicare pays for it. It's good for the patient or the recipient. It doesn't have to be. Now, we're not just talking patients here. We're talking Medicare recipients. So we want to keep them healthy in this model. So it's good from a financial standpoint, but those annual wellness visits also hit at least 10 of the quality measures for accountable care organizations. Now, for rural hospitals, those generally aren't quality measures, but there are at least 10 prevention quality measures that an annual wellness visit can take advantage of. In some of the early results coming from rural ACOs were that was a big stumbling block. We're simply not doing these Medicare wellness visits, and we're not hitting our quality guidelines, and we're not capturing the revenue. A second point, you talked about the coding, and coding is really important here. Another, kind of a lesson learned, and that is CMS, the federal government, thinks patients in rural areas are not as sick as their counterparts in urban areas, simply because of the coding. We tend to undercode, and because it's not always involved in our billing, or in our revenue, we've done this historically. So getting the coding right and being appropriate, not upcoding, but appropriately coding becomes a real key here, and I heard both of those mentioned. So what type of support did you get from the National Rural Accountable Care Organization, Caravan Health? What were some specific things they helped you with?
Well, I'd say there's several. From an education standpoint, they provided a lot of that for our core team. Dr. Cannon, their meetings and various opportunities from an educational standpoint. So that's one. The other is helping us understand how to use the data warehouse and the data to our advantage. That's one of the huge advantages of being in an ACO is gaining access to the data. As close to real time as you can get it, and certainly once you get it, you need to know what to do with it. And it's taken some time. That's been a learning curve, but we feel that we're finally able to break it down and make it useful. We're able to identify those high-cost drivers that are getting services, not necessarily in our community, but they may be attributed, say, to Dr. Cannon, but she may have a patient she's not aware of that's going, to various places for different types of care, and it's a huge cost driver. So when you gain that access, you're able to really focus in on the patient, and through care coordination, make contact with that patient, bring them in, and start helping them better engage in their own health and welfare, and take more control over that accountability for the care that they're actually getting. And what we found is, through Caravan's assistance and learning how to use the data engine, educating our team, they come on site quarterly and engage with our providers and answer questions. It's just helped tremendously get more involvement from everyone.
So, Lee, what I heard you say is to some degree you could identify particularly your high-cost drivers. And again, for those of you that may not understand the accountable care formula, let me just quickly spell it out. You take a group of, let's say, 12,000 Medicare recipients. You basically calculate how much money that Medicare spent on those 12,000 recipients, and you then provide comprehensive services over a complete year. And when there are savings, the difference between the cost the previous year and the cost this year, the savings are basically divided between the accountable care organization and the Medicare and CMS program itself. So eliminating waste from the system, I don't think, especially because there are quality measures that you have to hit, it's not like you're going to be motivated to undertreat, but you basically look at least in the initial stages here, at the really high-cost patients, and the information that you're now receiving for the first time, basically, is a comprehensive look at all of the Medicare costs to that particular patient throughout their medical experience. And the other thing that comes up is it also gives physicians a good idea of how much money has been spent when they refer patients and the quality of the care that is provided as well. Lee, is that pretty accurate? Anything you'd want to add to that?
Yeah, I think I'd add. Yeah, I think that was pretty accurate. I'd add a couple of things. One being the HCC coding and the risk adjustment. It's important to make sure, whether you're rural or not, to get the coding right, because after your mark is set, your benchmark, the curve you've got to get under, coding is extremely important for CMS to understand what type of patients you're taking care of. So an example would be if you have someone who's end-stage renal disease, but we don't code it as such. You're coding it as acute renal failure, which is a lot less weighted, but the person's really end-stage renal disease. The costs may be high, but they're not reflected properly with what the patient really has, the care that they're getting. So that's important. And secondly, miscalculated. You just have to really, again, the coding, and I'll just go back to it. I lost my second point I was going to mention. As rural health clinics, a lot of times you're billing the all-inclusive rate, and so you're missing out on some of the importance of coding. And so you have to do that whether you're a critical access hospital or rural health clinic, and certainly reflect better the population that you're treating and the care that you're providing.
Great. Dr. Cannon, we now have a care coordinator, obviously, that's been designated, and care coordination teams basically are intended to complement the work of the providers, the primary care providers in general. Could you talk about your interaction or the medical staff's interaction with the care coordination team or the care coordination individual, how that went? Has your role changed at all? Has anything been taken off of your plate so you don't have to do it now, or any new responsibilities?
Well, as far as the care coordination team, we have patients now enrolled in chronic care management and transitional care management, and we're adding new patients along the way. But it's really just been a compliment to how we are able to take care of our patients. With the chronic care management and the patients that we have identified to enroll in that program, she contacts the patient periodically to check on them, and she's at times identified. I can think of one patient, she called one day and he told her he was having some acute visual changes, and she got him into the eye doctor, and he ended up subsequently soon after that having cataract surgery. And he'd not come in for a visit expressing that he had any problems, but she was able to pick that up just from calling periodically. So it's really just been a compliment to help take care of the patients. The care coordination team also has been very good at helping us get referral letters back from specialists. That's been an issue that we've had, is we don't always get our referral documentation back when we've referred our patients. And that, of course, that's very important that we get the referral letter back so we know what happened at that visit. And they've really helped us start getting more of those referral letters back, which has been a big asset. In our transitional care, our patients that are being discharged from the hospital or discharged from the swing bed, by the time they come in for a visit, in the past, when they would come back for their follow-up visit, we would not yet have any documentation from the hospital. They would be there in the clinic for their visit, and we would have to call and try to get some records from where they were discharged. But now the transitional care team, when they show up for a follow-up visit from swing bed or from the hospital, we have all of their records, everything that happened during that hospital stay, and that really is a huge benefit for us. So it's been great.
And to add to that, we're capturing most of our discharges, if not all of them, to have a follow-up appointment with their providers. Some were falling through the cracks, some were making their appointments, some were not taking their medicines. And so from a medication reconciliation standpoint, that coordinator is able to get in there and really help the patient figure out, okay, what really happened, what am I supposed to do now? And secondly, we also are starting to look at patients that are on home health. Our providers oftentimes would, a patient would qualify, patient would go on home health, and they may not get the information back on how the patient was doing and what were the outcomes, or more importantly, what are the costs associated with that home health care. And so that's really a focus of ours right now, is looking at our patients that are getting home health, the high-cost drivers, and what services they're getting, so the providers can then be informed with, their patient, is there something going on that needs to be addressed from a medical standpoint? do they even need to continue to be on home health at all? And then finally, the last point would be a lot of our emergency department visits, patients not having a primary care provider, using the ED as a primary care site. Our care coordinator is taking a look at ED utilization and trying to identify these patients that have a provider or those that do not have a provider, and contacting them and attempting to get them in the primary care location for follow-up in the appropriate location. So we're seeing some decreases in our ED visits, the ED visits that need to decrease.
Right. So that I think that I get this question from physicians more than any other one, and that is, now you're going to put another task on my shoulders. I have to not only do all this other stuff and see these patients, but now I have this new responsibility. But what I heard Dr. Cannon say and you saying, Lee, is that there is now a team of folks possibly, and particularly the care coordinator, to actually help the medical provider. So the medical provider now has a team kind of at their disposal to help follow up with the patients, to do some of the work, et cetera. And one of the concepts that I've heard associated with this is that the medical providers start working more towards the top of their license, so they're not having to do some of the things they might have done before, but now there are resources available to them as well. Did I capture that right, Dr. Cannon, particularly because this is a huge question for physicians, and it's incredibly important that we get good information out to them. So was your life made harder by this, or did you actually find that the other resources were available to you now?
I think it definitely helps to have the other resources available. I mean, there is a huge learning curve in the beginning, trying to determine the most efficient ways to document things within your particular EHR that you have available to use, to make sure that when we query the chart, we can find those things for the quality measure. So, I mean, there is some, I would say there is some increase in the work initially until you kind of develop all your processes and determine how things are going to be done. But one of the things, too, that has helped is just engaging the nursing staff, and they're actually doing chart audits now based on the quality measures. And that really gets them familiar with what we're doing as well, so that to the extent that they can, when they're triaging patients, help have those things documented in the chart as well.
And I guess the bottom line would be, besides the workload, do you believe that this is better patient care? In other words, has this contributed to the lives of the folks, your patients, and the folks in the community? Do you think it's a positive in that regard?
Oh, I absolutely think it's positive. I think in the day-to-day, when we're seeing patients, we're focused mainly on, most patients come in when they're ill. I mean, they come in for a sickness, for an acute issue, and we're focused on treating their acute issue, and sometimes those preventative measures that we all know that we need to do, unfortunately, fall through the cracks. And really, we're focused so much more on keeping these patients healthy and doing what we can do to make them healthier. I mean, it's absolutely worth all of it.
Switching gears just a little bit, Lee, tell us, what have been the financial results so far? What is your accountable care organization achieved to date?
Okay. So our first year benchmark was set by CMS at $10,692 per Medicare beneficiary. Through 2016, we were able to get it under that number by $901 to $9,791, which was an adjusted benchmark of 8.4%. We lowered our inpatient costs in 2015 from $3,443 to $2,832, which is a almost 18% drop in inpatient cost. SNF costs dropped from $1,157 to $896, which is almost a 23% drop. And then ED visits per 1,000 Medicare beneficiaries dropped from 941 to 817. So that's a 13% decrease, which led to the shared savings of right at a projection of $10.9 million for 2016. So the question oftentimes is, well, gosh, you reduce the cost by almost $11 million. How did that affect your bottom lines? How did that affect your revenue as organizations? So we looked at everyone in our ACO's gross inpatient revenue, gross outpatient revenue, and net patient revenue. Our gross inpatient revenue actually went up by 3.5% combined, from $376.8 million to $389.8 million, which was a change of $13 million. But the cost again dropped by $7.4 million. That cost dropped by per beneficiary of about $600 or so per beneficiary. So the revenue went up, but the cost went down. So that was a good sign. On the outpatient side, and this is where most of all of our revenue is generated combined, revenue went up by $71.3 million in that year alone. The net revenue altogether went up by $29.8 million, but the cost per beneficiary went down, or the total cost, or the difference was, it dropped by 8.5% to create a shared savings of $10.9 million.
Wow. And they, like I said, I was in Texas last week bragging about you guys. And the second question, besides how did that happen with the two different states, was how do they do that? So can you give us a little bit of a feeling for how did you increase revenue and contribute to the, and then have accompanying lower cost for your Medicare recipients?
Well, I think you have to attribute it to performing more annual wellness visits that spur additional outpatient testing that are necessary for prevention. Well, it's a colonoscopy, a mammogram, hemoglobin A1Cs, various things. Adding in chronic care management, trying to get those folks that they have multiple things going on, get them into the provider in the right site, or the right side of care, addressing their issues before they become, very acute. Taking patients that are being discharged from the hospital and managing their care at discharge. We're seeing a drop in our readmission rate. We're getting them in the outpatient part of our business and keeping them at bay, so to speak, from the inpatient side. One thing we're about to begin performing in our clinic is behavioral health assessments, mental health services that are necessary. We provide that from an inpatient standpoint and an outpatient, an IOP standpoint, but we don't provide counseling individually or integrate that well in our primary care setting. And just really improving on patient satisfaction scores, gaining access to the data, seeing where our patients are going, and keeping them local instead of going to, say, urban settings where the cost of care is higher. It's a proven fact that in urban settings the cost of care is higher than it is in a rural setting. So by steering our population and keeping them here locally and being more proactive, we're increasing the revenue at our local systems while at the same time reducing the cost per care, because we're doing more prevention, more wellness, more services on our patient side instead of waiting until they have an episode and need an acute level of care.